Let's talk about persistent pulmonary hypertension of the newborn. Persistence of increase in pulmonary vascular resistance after birth. It is associated with abnormal development and postpartum adaptation of pulmonary vasculature. Risk factors include aspiration of meconium, stained amniotic fluid, and neonatal pneumonia. Leads to right to left shunt through foramen ovale and ductus arteriosus. Newborn presents with signs of respiratory distress, okay, which is tachypnea and cyanosis. Preductal O2 saturation is often higher than the postductal saturation, and equal pulses with no delay. So again, they're trying to differentiate from the top one a little bit. Top is the coarctation of aorta, in which case there wasn't equal pulses, so there was meaning low pulses in the lower extremities, delayed pulses in lower extremity, while hypertension in the upper extremity. Here we just have no delay. On top of that, but the O2 saturation is affected. Preductal, you have increase in O2 saturation, but postductal, you have low O2 saturation. So what is this all thing we are talking about? So it is persistent pulmonary hypertension within the newborn. So a baby is born with respiratory distress like tachypnea and cyanosis. And when you check the O2 sat, preductally it is high, but postductally it's low, and there is equal pulses. You're thinking about persistent pulmonary hypertension. And why did this develop? Well, this developed because you have abnormal development, either one thing, this, and the postpartum adaptation of the pulmonary vasculature did not happen. And risk factor, again, what caused it? Aspiration of the meconium, which would be stained amniotic fluid, and neonatal pneumonia can cause all of this, persistent in the pulmonary hypertension of the newborn. Okay, now looking at the next one, what do we have here? Is the congenital cardiac defect associations. So just the names and what they are. So prenatal alcohol exposure, which is known as a fetal alcohol syndrome. It is associated with VSD, PDA, ASD, tetralogy of Fallot. So again, if you think about it, you have VSD, PDA, and ASD. All of these are what? Left to right shunts, right? Delayed cyanosis, right? Like delayed cyanosis meaning it's going to occur later in life. And the only one thing which is right to left shunt, that is your TOF TOF, tetralogy of Fallot. So alcohol, look, it's a lot of defects, just the hard defects. Congenital rubella, PDA, pulmonary artery stenosis, septal defects, Down syndrome, high yield. Again, AV septal defects, endocardial cushion defect, VSD, ASD. So VSD, ASD, and AV septal defect, meaning endocardial cushions defect. Infant of patient with diabetes during pregnancy, so gestational diabetes. Transpositioning of great vessels, truncus arteriosus, tricuspid atresia, VSD. So if you look at them, except VSD, all you have majorly right to left shunts, and then VSD on top. And if you look at the fetal alcohol here, was majorly left to right, and just TOF was extra. Marfan, MVP, mitral valve prolapse, thoracic aortic aneurysm, dissection, regurg, lithium, Epstein anomaly, Turner, bicuspid aortic valve, coarctation of aorta, as we talked about, coarctation of aorta, Turner, Williams syndrome, supravalvular aortic stenosis, DiGeorge syndrome, which is 22q11 syndrome, truncosarteriosis, and tetralogy of Fallot. Okay, so all of these are just the high yield things to look at whenever you want to look at the association versus defects.